So with that, now we move on to the next section, which is basically posterior segment, and something which I do know a bit about. So for that, I would like to invite Dr. Daraius SHROFF. He's a vitreoretina surgeon at SHROFF Eye Centers, and he'll be talking about the newer indications, which is amniotic membrane grafting in recurrent macular holes.
So good morning, everyone. I'd like to thank the scientific community for this opportunity. So now we're going to move right on from the anterior segment right into the retina and dive into the retina. And we've covered this into two segments. I'll be discussing macular holes, recurrent macular holes basically, and Dr. Gagan Bhatia will be talking about optic disc pitch. So like Dr. Rushad said, retina doctors have stolen the amniotic membrane from them, and now they're using it for their cases. So let's see how useful it is. So basically, although macular hole surgery has got very refined and we have primary closure rates of more than 90%, we have certain cases where we do need help. We need something to help close these holes. So basically, recurrent macular holes where ILM is already peeled. So this is where the inverted ILM flap is not possible. And sometimes you have very high myopes, like you can see in this picture here. So this is another case where the contour of the eye makes it very difficult for the hole to close. We were always very curious to use ham in challenging situations like these. We tried a couple of times but found it very, very difficult to handle. What are the challenges faced when we use amniotic membrane in the posterior segment? We saw beautiful videos from Dr. Rushad and Dr. Dipinder. So for them, it's easy to use because they're putting it on the surface. But for us, as retina surgeons, we found it difficult to visualize because it's transparent and thin, difficult to visualize extraocularly, and intraocularly with high myopes, it has a very poor contrast. So first was visualization. Second is sizing. So the sizing is irregular and arbitrary, which leads to non-optimal grafting. So that was the second option. And the third was very important, placement. It's sticky, it sticks to forceps, and is difficult to place accurately. And if you just shove it into the hole with the forceps, you have a potential of damaging the RP layer. So because of this, we came up with this SSS toolkit for ham grafting. I discussed with my friend Dr. Dilraj Grewal and Dr. Gagan Bhatia. So we planned a workaround for each step. So this was an easy technique developed by us, so I'd like to discuss it with you. So can I have the music also? Can I have the
Audio
music?
visual, can you play the sound, please?
Yeah, so this is the toolkit. So it contains of the dye, the tools we use for this technique. So let's go on. So you can see how difficult it is to visualize. It's transparent and it's basically invisible. So this is the problem, and let's see the solution. So solution is to stain it. So we use brilliant blue dye, and you see how this transparent membrane suddenly becomes visible with the dye. So what we do is we stain it, and then we copiously wash off the stain multiple times. And just this simple act makes it so much easier to handle. The second, shaping and sizing. So see on your left side how inelegant this is, cutting it with scissors. You have ragged edges which can get stuck in the ports. So firstly we size it by using this formula. So we add the base diameter with the MLD and divide it by 2. So this formula helps you to decide what size of membrane you need. Optic disc pitch, Dr. Gagan will be discussing with you. And then you see these are very simple dermal trephines which are very cheap, very easily available, and you just use this to punch and get the optimal size graft. So this was a very simple solution of a problem. Third is placement. So placing it is always an issue. So you see the forceps, it gets stuck, it doesn't come off, so it's really not very elegant to use. So we've discussed and we devised the sliding technique. So here we use a bimanual technique, put a chandelier, and one hand you can have the tannos, and one hand you can have the nitinol loop, or you can have both hands, you can use the flex loop if you like, and see how elegantly you can put the amniotic membrane using this technique. So let's discuss a case. So this is like a very scary high myope of axial length 30 millimeters, had a recurrent RD with a macular hole, and she lost vision post SOR. You can see this huge macular hole and a total detachment. So we did a revitrectomy with tug of war for the membranes, etc., did a RR and placed a 3 millimeter graft. So I'll just show you the video. So you can see here, there are some membranes, there's some posterior hyaloid, so we remove that. And then we find that this is really difficult area, very, very tight. So in this situation, it's better to do a relaxing retinotomy. And with cautery, we're marking out these areas. And then we have to reflect the retina because there's some subretinal membranes and bands. So we remove the bands and membranes. Always be generous with your retinotomy. Once you decide to do it, you can make a larger one. So this is, and then under PFCL, we are unrolling the retina. Now you can see carefully the membrane. This is the amniotic membrane being taken out from the punch. And here you can see we have used 23 gauge for two reasons. One is high myope, and second is to get this membrane goes through much more easily in a 23 rather than 25. Sometimes in 25 it gets stuck in the ports. And this is the bimanual technique. So with the with a nitinol loop and a tannose, we are kind of unrolling it. And sometimes it crumples up very badly, and if you use forceps, it can be very rough. So this is the way we kind of unroll the amniotic membrane. And then we do the laser, and a lot of relief at this stage, and we do the PFCL oil exchange. So this is the last step of the surgery. And a beautiful result. So you can see up is the post-op picture. The retina is stable. Vision has gone from hand movements to 6/60. And you can see how beautiful the OCT is on top with the closed macular hole with the graft. So this is a technique we published along with our colleagues from Duke Eye Hospital in the US, the staining and sizing technique for human amniotic graft in refractory macular holes. And this was published in JVRD recently, and these were the patients who were included. So I would encourage you to go through the full text of this article. So just to end, macular hole surgery is standardized and simple, but still we have challenging situations, and AMG offers a wonderful scaffold tool for these cases. Thank you.
Dr. Daraius, it may be a stupid question to ask, but tell me, can you use the retina tissue in place of amniotic membrane because you're doing retinotomies and
Yes, so that's not, in fact, it's a well-established technique of using a retina autograft. But sometimes when I find if they're very high myopes, etc., we always taught to kind of save the retina. So if you have very high myope, you want the procedure to be as short as possible. So that does take time, little chance of bleeding is there. And if you have a macular hole, recurrent macular in attached retina, then you have to make a bleb, detach the retina and cut it, which is cumbersome, whereas this is available freely, you can just put it in. So it's a more quick in, quick out kind of procedure.
Another question, so we've seen when we stain capsules with trypan blue, the elasticity and the tensile strength changes. So have you all seen anything in that comparing? It would be worth actually seeing that.
We didn't think, I mean, I don't
think so. I
that.
think the basic answer to this first question, to the question is that I think, as you said, that we took over the amniotic membrane graft. So I think you need to appreciate the fact that we basically took a city car and turned it into an AMG, a Mercedes, much more suave. So I think it's a very tiny tissue. So I don't think the tensility and everything can really be, I don't think it can be adjudged as such. But the experiments that we did, with the membrane outside and as well inside, I don't think that with that size of a graft, we've been able to see any difference per se.
I want to ask the cornea colleagues, how long does the amniotic membrane last in your cases?
Few weeks typically.
Yeah. If there is inflammation, maybe just a matter of few days, because basically the protein of the basement membrane is rapidly digested by the neutrophils which are there. And in patients in which there is no very active inflammation, then yes, it will last for anywhere from 2 to 6 weeks also.
Because we have patients over 6 years and the membrane does, you still see that white reflex. So 5-6 years we are still, so we don't know what the endpoint in retina.
So I think the one more point that I wanted to discuss, which was I think spoken about in Dr. Rushad's presentation. I didn't ask it then, kept it for now. So you had spoken about using amniotic membrane grafts for non-healing epithelial defects basically. So when we use amniotic membrane grafts in the center of the cornea, And what about the transparency? Because that is one basic point that everybody asks when we are using it in in macular holes. Because ultimately, if you see even the cases with Dr. Daraius have presented, I think there is increase in vision, and even with how does that translate? I mean, if it's just acting as an opaque scaffold, or it does clear out and lets you have some vision.
So anyway, it gets absorbed over a period of time. So for us, it's mainly a scaffold, and the host's epithelium grows and covers up the epithelial defect, and the amniotic membrane dissolves over a period of time, and we remove it. So I think it's pretty much that happens.
Right.
It doesn't persist in the epithelial defect actually.
Yeah, maybe because that was also what we've seen, like people who, I mean, there are reports where people have used the amniotic membrane as an overlay and macular holes. And if you see the membrane which is over the retinal tissue, that starts to kind of roll up. But probably the inlay, probably on the RP, it kind of stays because there is nothing growing under it, probably. That could be one of the answers. Yes, sir, please.
Sir, do you see a role of AMG in dry eye diseases as a primary go-to therapy?
So in very severe dry eye patients who are not responding to copious lubrication and even a bandage contact lens, sometimes you can combine it with a tarsorrhaphy along with the punctal cautery, because amniotic membrane does have, it retains the moisture better because of its nature, and it can provide you relief for maybe around couple of weeks and can help you tide over that extreme amount of surface erosions which come in these severe dry eye.
So if we have started cyclosporin, after that also it will reduce the inflammation, or you combine it with AMG and cyclosporin?
So the topical treatment would be definitely what you would do first. In a very severe dry eye, you can look at things like serum eye drops as well. We prepare it routinely for our severe aqueous deficient dry eyes, and that's what we use. The AMG is more a last resort, and then of course you would combine it with things like mucous membrane grafting as well for dry eye. You can use that. That tends to work better. Our group is not doing work on salivary gland transplantation, but that is also one method of counteracting the dry eye. The AMG, like Dr. Dipinder mentioned, is an initial thing to tide over the inflammation and give you time to again go in with a secondary procedure. Topical therapies now with things like liftigrast available, cyclosporin, you would definitely start with that. In aqueous deficiency, serum eye drops tends to work well. Systemically, you can give pilocarpine tablets. Again, those have a plus minus role in aqueous deficiency dry eye, but those can be tried.
Thank you.
So basically, amniotic membrane brings along a lot of growth factors, and these growth factors they help the epithelium to regenerate faster. But obviously, it's a temporary thing, but helps you tide over that crisis time when the dry eye is very severe.
So right now we are seeing so many ITP people are coming with dry eye problem, and they are very much pertinent about our MGDs will go and our symptoms will reduce, and these things will go, and they are very much aggressive about their treatments also. They'll read on net and they'll come why can't you do this transplant to us? So, what is your opinion about that? We had some patients, nursing staff and all that, they'll be very keen about this amniotic membrane transplant.
No, I think we have to be very scientific in our approach, and we have to respect the limits of any particular medical therapy. And amniotic membrane, the decision has to be taken based on the clinical findings only.